Welcome, everyone. We're just going to allow folks to filter in from the waiting room, but in the interest of time, we will get started. So welcome to the McMaster Midwifery Research Center rounds. This is the final series or the final presentation in our series of rounds for this year. And then we're going to take a bit of a summer break. These rounds are open to everyone. We like to share the latest midwifery-related obstetrical perinatal research, and it's been a great series this year with some real highlights. And at the end, maybe I'll summarize a few of those and point you in the direction of our website. Before we dive in, though, I just want to introduce myself. My name is Beth Murray Davis. I'm the scientific director of the MMRC. As you join, please make sure that your mics are off and your video is off. Note that the presentation will be recorded, and again, we'll post those on our website shortly. Before we begin our rounds, I would like to offer a land acknowledgement. So I'm situated on the land similar to McMaster University, although I'm at home today. And both of these lands are located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. And this land is also directly adjacent to the Haldeman Treaty Territory. And I think when we offer a land acknowledgement, it's important to be reflective and to be mindful of our actions so that we go beyond just offering these words. And as a settler here on Turtle Island, I commit to actively reflecting on and fulfilling my treaty responsibilities. And I offer this land acknowledgement in the spirit of reconciliation. So I would like to introduce to you our speaker for today, Dr. Luseadra McKerracher, who will be presenting on community engagement and anti-racist approaches to pregnancy, health, knowledge exchange, and racialized newcomers in Canada and Denmark. And Luseadra is actually in Denmark at the moment. I'll do a little bit of a bio to tell you more about her in a second. But because of the time change and the hour of the day over there, Luseadra has actually pre-recorded her talk, and we're going to show that. But she is here and happy to answer questions, and we're still going to have a good opportunity for Q&A at the end. But it just means a little bit more predictability in terms of how that talk comes together, given the time change and late hour. So that's our plan for today. And let me tell you a little bit about Luseadra. She's a junior fellow at the Aarhus Institute for Advanced Studies, an assistant professor in the Department of Public Health, and a member of the Platform for Inequality Research, Aarhus University, which I think is a PIREAU, P-I-R-E-A-U acronym. And so that's all at Aarhus University in Denmark. And that's where she does community engaged research and health promotion work focused on identifying and reducing nutritional, housing, and other environmental inequities that affect adolescents and folks during preconception, pregnancy, and perinatal health. This work is framed using a developmental origins of health and disease, or a DOHaD perspective, with a view towards supporting health and preventing disease throughout the life course of parents and their children. So as I said, our game plan is to have this research talk where we're going to hear a little bit more about this very interesting comparison between Hamilton or newcomers in Canada and Denmark. And then we'll have time for questions. So I will turn it over to our lovely pre-recorded video, and we'll pop back in, and Luseadra will join us for questions in a bit.
Hi, thank you so much to the organizers and particularly to my collaborator and former mentor, Professor Beth Murray Davis, for inviting me to be a part of the McMaster Midwifery Research Center rounds. I had said I was going to give a talk called Community Engagement and Anti-Racist Approaches to Pregnancy Health Knowledge Exchange with Racialized Newcomers in Canada and Denmark, when I first agreed to give this talk a long time ago. But now I realize that I'm actually not really going to talk about community engagement. It's not necessarily explicitly anti-racist. There's really nothing about knowledge exchange, but it does have to do with racialized newcomers in Canada and Denmark. But I haven't come up with a new title, so I'm just sticking with this. No, the slide doesn't want to advance. Good start. Here we go. Okay, so the plan for what I hope is about the next 45 minutes or so, I haven't timed it, this is unscripted. Let's see, is to start with a micro mini introduction to the concept of DOHaD, the Developmental Origins of Health and Disease. Secondly, to talk about two sets of findings from a project that I was involved in called the Mothers to Babies study, which ran here in Hamilton. And I'm going to give you 2 spoilers right now. The findings from the 2 studies that I'm going to talk about suggest that food insecurity and racialization exist, and that they're also probably bad for pregnancy health. Oh, sorry. Then I'm going to talk a little bit about Denmark and the Danish perinatal health and Danish perinatal health inequities, briefly touching on something called the ghetto or parallel societies policy. I'm going to talk very briefly about some super preliminary findings from the Supporting Pregnancy Food and Nutrition Security, or SPOONS, in Denmark project, for which I am the PI and have been running for the last 2.5 years. And I'm going to try to compare the Danish and the Canadian cases a little bit, and maybe try to glean an insight or two from that, and talk about some implications for policy and practice, possibly, although I'm hoping that we will get into that more in the Q&A. And because I haven't bulleted that much in advance here. So the developmental origins of health and disease, or DOHaD hypothesis, was originally posited by a professor of epidemiology, Dr. David Barker, at the MMRC Life Course Epidemiology Unit in Southampton in the UK. And the basic idea of the DOHaD hypothesis is that early life environment, and I say environment in sort of the broadest possible sense, so things as wide or diverse as nutrition and diet, as psychosocial stress from things like war, also from other sorts of like interpersonal conflicts, discrimination, all kinds of anything that causes what we sort of would register on a conscious level as stress. Then also like microscopic disruptors, things like toxicants and pollutants, as well as bacteria and viruses. All of those things contribute to the environment in the earliest stages of life, from just before conception, periconceptionally, through pregnancy, and through the first 2 years postpartum. And the idea behind the DOHaD hypothesis is that a developing embryo or fetus will make some very slight adjustments in ways to respond to cues about the environment, the nutritional environment, the stress environment, etc., and do so in ways that will probably statistically improve chances of short-term survivorship, but do so at a cost, and that will then sort of accrue across the short-term phases of development and compound in ways that then affect subsequent developmental growth and growth trajectory, and accrue until adulthood. They affect adult risk for various non-communicable diseases, from things like cardiometabolic or cardiovascular disease to various mental health challenges like anxiety and depression, to other sorts of metabolic diseases like type 2 diabetes. Now, there are various shortcomings of the DOHaD hypothesis, but overwhelmingly, it's particularly sort of like from a social and policy sort of angle, and we can maybe get into that later, I don't know. But overwhelmingly, the data, so Dr. Barker proposed this hypothesis more than 30 years ago, and overwhelmingly, the data from animal models, from clinical trials, from large-scale epidemiological studies, they all seem to show that those very early life exposures do indeed affect developmental trajectory and do indeed affect subsequent disease risk, independent of adult environment, and adult lifestyle factors. So one clear benefit of the DOHaD hypothesis is that it gives us some insights about how we might want to target our attention, our resources, how we can get the biggest bang for our buck as researchers, as clinicians, as people that just community members. And this goes just generally speaking for promoting health, but maybe it's particularly valuable when you're thinking about the goal of health equity, making sure that everyone has truly equal chances to live healthy, full lives with high subjective well-being and reasonable life expectancy. And what the DOHaD hypothesis tells us is that if we want to work towards health equity, that we have our very limited resources, we're probably best off focusing just before conception or preconception and through the first, and then through pregnancy and the first couple of years postpartum. The DOHaD hypothesis was running in this, was sort of back of mind for the Mothers to Babies project. And the Mothers to Babies project, some of you may have heard of it, because it's a Hamilton-based community project designed to look at factors that might affect pregnancy, health, well-being. There's a particular focus on nutrition, but just generally pregnancy, health, and well-being among community members in the city of Hamilton, with the idea of making Hamilton the sort of the healthiest environment that it could possibly be for pregnant people and their families. So we launched the Mothers to Babies. I was hired to run the Mothers to Babies study by Professor Deborah Sloboda, who's a fetal physiologist and also community health researcher at the Department of Biochemistry and Biomedical Sciences here at McMaster, or there at McMaster. I'm no longer there. So she set that project up and asked me as a social scientist. I was originally trained as an anthropologist to run this community outreach project together with a number of other excellent scholars, including, as I mentioned, Beth Murray Davis, who was a member of this team and has worked on a number of analyses on the Mothers to Babies data. So the Mothers to Babies study combined qualitative data collection using focus group discussions and interviews with healthcare providers, as well as with pregnant people and new mothers and some other support people, as well as a survey on pregnancy, health, and nutrition and various social determinants of health and outcomes. And we surveyed about 300, we had complete survey responses from about 350 folks between 2017 and 2018. And we also ran interviews with 63 participants, both from the care provider and the care receiver side of things. We had a number of expectations, as I'm sure all of you do, around things that we know are sort of known social determinants of health in general and pregnancy health in particular. We, of course, expected that income or lack of income would play into how people experience their pregnancies and also would affect their pregnancy health outcomes. Likewise, we knew that education would be part of the story. And there were some other things that were maybe a little bit less obvious, things sort of like more on the policy side of things. So that's Hamilton City Hall, things like housing quality and location, things like pollution, things like walkability and access to nature, things like community supports and sort of family structures. We expected some of those things to play into the discussion as well. But then there were also a couple of things that we ended up coming to, the things that we're actually going to talk about today, that we hadn't planned to measure and hadn't expected to be an important part of the social determinants of pregnancy health in Hamilton's story. And those are racism and racialization and food insecurity. So the racism side of things is kind of an interesting. So we had this survey out, and we had some questions that maybe could have to do with a person's individual experience of being racialized, although we didn't conceive of it in that way at all when we designed the survey. And we also started talking to people, and what we found pretty quickly, and what we heard again, I only have one example here, I think, but what we heard again and again were things along these lines. For our newcomers, so people who lived in in Canada for 5 or fewer years, they have to navigate a whole new country without even knowing the language. They just don't know how to advocate for themselves. And we heard all kinds of sort of newcomer related challenges around language, around being sort of excluded from various benefits, having extra challenges around like visa renewal and yeah, all kinds of things. What we didn't hear, not once in 300 pages of transcripts, not once did we hear the word race or racism. And I think this is probably because we, sorry, I think that's probably because we collected these data mainly in 2018. And so now looking back from a sort of a post-2020 George Floyd like major groundswelling of anti-racism discussion, it seems crazy that we didn't ask any questions and that it also just didn't spontaneously come up in conversation. But racism did not come up in conversation. The reason we did these analyses that I'm about to show you now were because that after we'd done sort of our other core M2B analyses of the survey data, someone asked me, I was invited to participate in the Racialized Maternal Health Conference in 2019, I think, in Toronto. And I thought, I'll finally look at those data around where we ask people to identify their own race and or ethnicity and see if that is associated with any of these outcomes. I don't really think it will be. It's probably like, or if it is, it's mediated by basically socioeconomic position, which still sucks, but you know, I don't think it's going to be an independent predictor of various pregnancy health outcomes. However, so I did, just for this participation in the conference, I decided to do these analyses. And so I've backed out some measures of pregnancy health that I thought might be sort of worth digging into. Sort of the most obvious tractable one was whether or not a person reported being diagnosed with a pregnancy complication. We also looked at things around pregnancy weight gain, worry about pregnancy weight gain, thinking that might have to do with some sort of stress experience and like body perception. This thing, which this variable, which I'm not going to talk about, I actually don't think it's that interesting. And then this overall health, whether or not a person reported their overall health prior to pregnancy compared to their experience of overall health, their subjective health, as now I forget where I started the sentence, but we looked at whether or not there were changes in how a person perceived their overall health pre-pregnancy compared to pregnancy, and whether or not that declined, stayed the same, or rose. And then we looked at each of those indicators as a function of their racialization status, so whether or not they identified as white or not. It's a little more complicated than that, but for right now, that's all I'm going to tell you. As well, while adjusting for all of the major sociodemographic factors you might expect to confound this. And then we made logistic regression models based on that. So just a little bit about the respondents. So as I mentioned, there were 350 respondents, and they came from all wards of Hamilton. 96 of the respondents identified as not white, non-European, and did identify as a race and or ethnicity that we might expect to be like a person would probably be visibly not white, and we'd expect them to be racialized in some of their interactions. 21% reported living with low income of the total sample, not the racialized sample. 10% were newcomers to Canada. They moved here in the last 5 years. The whole sample had a mean age of just under 31. And about half, or exactly half actually, had previously had a child, and the other half were nulliparous. So basically what we found was, of the 7 models that we made, the inferred racialization experience status was independently associated with a pregnancy health or health experience indicator. I'm just going to show you 3 out of those 5 models for the sake of time, the most interesting ones. So first, the story with complications. So our adjusted odds of a respondent reporting a diagnosis with a pregnancy complication as a function of her racialization status. That was a twofold increase, adjusting for age, gestation week, socioeconomic position, pre-pregnancy BMI, and pre-pregnancy overall health. Also, quite striking was the risk of gaining pregnancy weight at a lower rate than, or gaining pregnancy weight below recommendations or below guidelines. That was being a non-white respondent was associated with a 2.3-fold increase in risk of gaining insufficient weight or gaining weight below guidelines. And then this subjective health experiences indicator. So adjusted odds of reporting overall health that worsened during pregnancy, that was 2.7 times higher among the respondents who identified as non-white. So basically, there are at least 3 clear differences in pregnancy health and health experiences between racialized and white respondents to the Mothers to Babies Hamilton survey. To recap, those was a twofold disparity in odds reporting a diagnosed pregnancy complication. And there's a number of possible explanations for this. One is that it may reflect more surveillance of racialized pregnant bodies and thus more diagnoses, or it might represent under surveillance and or barriers to healthcare getting in the way of prevention or mitigation, meaning that the actual risk of developing a complication is higher, or complications might actually result directly in or from the experience of racialization, the stress that comes with discrimination, for example. And I'm sure there are more. So again, we found a twofold or more than twofold disparity in odds of gaining pregnancy weight below recommendations, and there are lots of explanations for this. It may reflect an inappropriate reference population or in reference populations for the guidelines around pregnancy weight gain, or it might have to do with under surveillance and lack of support. I don't know, there's some sort of like auto thing that keeps making my slides advance before I'm ready for them to advance. What am I trying to say? So it may reflect inappropriate reference populations for the guidelines on pregnancy weight gain, or it might have to do with under surveillance and lack of support, or it may have to do with differing cultural attitudes about energy inputs and outputs during pregnancy, when it's appropriate to rest, when it's appropriate to eat, what you should eat, etc. Yeah, again, we don't know. These are sort of post hoc, very speculative hypotheses about what's going on. And lastly, we found there was a threefold disparity in likelihood of perceiving overall health to be worsening during pregnancy. And this is, I think, super, super interesting, and one that I wish we had other data to dig into deeper with. But we think it may reflect an increased contact, the result of increased contact with the health system that comes with pregnancy, which can increase stress and feelings of alienation if you already don't feel like the health system is for you. This is it might have to do with perceived or real discrimination and stigma when interacting with the health system or health professionals, or just being out in the, or it might have to do with a general increase in attention, especially negative attention to the pregnant body when you're just out in public, and all of a sudden, when you're visibly pregnant, people just pay a lot of attention to you and judge you in lots of different kinds of ways. And yeah, if you're a racialized person, then you get this like double or triple whammy of people attending to your body and monitoring your body that I imagine could affect your subjective well-being and experience in the world. So that, I'm just going to go back. So again, this racialization study, this was driven by a very sort of external pressure to do some analyses so that I could participate in this, and the M2B team could participate in a particular conference. And we ended up finding some really, really stunning things. So that was the sort of surprise social determinant of health that we hadn't planned on looking into, and found something fascinating and important. Other thing that we hadn't planned on looking into But we found inductively that we needed to look into through after we started running focus group discussions with pregnant people and especially with care providers, was the issue around food security and food insecurity. So we heard again and again and again the phrase food insecurity, and we heard things like many of the people we work with just don't have the money to buy food from public health nurses and public health dietitians working at Welcome Baby. We heard similar things from pregnant people and new moms themselves. So even though that wasn't sort of on our radar to start with, we thought we didn't put anything to measure food security in our survey, but we have some things that that might speak to it. Let's see what we can do to try to measure this as best we can after the fact, now that we know that this is such a big thing for people in Hamilton. So just briefly, so that we're all on the same page, what is food insecurity? I've always really liked this definition, the inability to acquire, consume an adequate diet quality or sufficient quantity of food in socially acceptable ways. That's really important. Or the uncertainty that one will be able to do so. So that second part is also really, so the socially acceptable component is really important. So it's not just about calories or micronutrients or whatever, but also about like the time and the way that food is served, food is served, and also the kinds of ingredients that can be accessed, and if they're like are culturally meaningful and reflect like values around food. And then the uncertainty that one will be able to do so. So this issue of like, are you free or are you not free from worrying about making sure that no one's going to go hungry? And there's lots of different degrees of these experiences. And so in some more extreme forms, we might be talking about emergency food resource use, which is associated with declines in food quality and also stress and stigma and all kinds of things. It may actually involve like literally skipping meals and going hungry. And that does happen in Canada, unfortunately. We know that from national survey data. Surprisingly high rates. And then it also might just mean, it may also mean like cuts to the quality of food, buying more things that are self-stable and ultra-processed, calorie dense, and just generally like maybe not great, but at least you have, at least you're eating, but it's maybe not really what you want to nourish your body with when you're pregnant, when you're a care provider, etc. Given that we're talking about meal skipping, we're talking about reductions in quality of food, maybe this isn't surprising. I've just picked one bit of data. This is US data, actually. I should have picked Canadian data, but showing this sort of gradated relationship between food insecurity and risk of chronic diseases among US adults. And as you can see, it's like there's really a dose response sort of thing where people who are living with severe food insecurity, so this is like really actually running out of money and meal skipping and major reductions in food quality and blah, blah, blah. 53% of people living with severe food insecurity are living with one or more non-communicable diseases, compared to 37% of US adults who are fully food secure, and this is adjusted for age. Yeah. So being basically the headline there is being food insecure is bad for health. Okay, like I mentioned, we didn't actually really measure food insecurity on the M2B questionnaire, but we did have a number of questions that had something to do with, they were sort of food security scale adjacent. I won't go into the details, but there were 6 questions that we decided were close enough to like food security questions that we could at least do some back of the envelope calculations. And we based on these, we estimate about 21% of the mothers to babies survey respondents as being food insecure. And that's actually not surprising because of the way we recruited respondents for like how we promoted the survey, which was very heavily in pregnancy services for people living with all kinds of vulnerabilities, and in sort of with a particular focus on the most impoverished neighborhoods, or Hamilton's priority neighborhoods, as they were called at the time. So anyway, yeah, 21% of the sample was food insecure according to our scale. And okay, we're not talking about huge numbers here, so let's not get too excited, but still, we found that in these data, there was a pretty like a much larger than you would expect by chance overlap between the people who reported diagnosis with a pregnancy complication and who were food insecure. I'm not going to go through the breakdown of these complications, but yeah, about half the folks who were food insecure also had pregnancy complications. Much fewer pregnancy complications among the food secure folks. When we modeled this, adjusting for at least a couple of important sociodemographic and health factors, we found that food insecurity scale predicted the change in, or predicted risk of reporting a pregnancy complication by, I can't remember, 1.2-fold. I'm going to show you on the next slide, actually. So this is our indicator of food security down here, blah, blah, blah. 1.2-fold increase, adjusting for maternal age, gestation week, and self-reported pre-pregnancy overall health. And it was around the same. I think there was some modeling problems with adjusting for socioeconomic position, but the general result held if we did that. So this is basically to show that probably food insecurity is associated with a higher chance of reporting metabolic complications of pregnancy. And I didn't get into this in this particular talk or this particular analysis, but there are sort of good theoretical reasons to have actually expected exactly that result. And the tiny little M2B analysis that we did, those results are consistent with the prediction that we would have gotten both from theory and from elsewhere in the literature, that pregnancy complications risk increases with food insecurity. I just want to acknowledge the work on a systematic review of literature that two excellent McMaster undergraduate students, Julia is no longer an undergraduate student, but at the time they worked on this, on Julia Larabiciosa and Kate Taplin, were undergraduate volunteers on the project I'm currently leading, and they were involved in running this evidence synthesis on food security, and that they also looked at housing security, but I'm going to skip ahead and just say that they looked at they screened 317 articles and found some pretty striking evidence that food security is, versus food insecurity, is associated with pregnancy. Food security is associated with a better pregnancy and birth outcomes, as well as with infant and child outcomes a little bit like further down the road. And the impacts were particularly profound if there were overlaps between food and housing insecurity. But yeah, I don't have time to really unpack those results at this point, but I just wanted to acknowledge that those M2B analyses fit in a sort of bigger picture, and that the literature generally suggests that there's the literature as well as theory suggests that food insecurity should be associated with worse pregnancy health outcomes. So we don't want it. Food insecurity, bad. Going to recap that, and it's particularly bad. Going back to the DOHaD perspective, these two studies that I just talked about, hopefully should show you that racism or racialization and food insecurity, they're bad to start with, but then we know that because the developmental environment has in the very earliest stages of life, including pregnancy, or maybe especially pregnancy, have these outsized impacts on later life development and developmental trajectory, which of course affects later life health, later life health outcomes. So racism and food insecurity, bad to start with, extra bad during pregnancy. And I assume that anyone that might be listening to this probably feels like me, that that's unacceptable. We live in wealthy, powerful countries that have the resources to make sure that food insecurity isn't a thing. Ideally, could probably also make sure that racism isn't a thing. And that's going to have downstream consequences for population health and health equity. Are we going to actually make sure that that's a priority? Are we going to do something about it? What are we going to do about it? I had the beautiful dream that maybe there was a country out there with a really generous welfare state, and really sort of high positive and really high value on what in Danish is called ligestilling, or equality in society. And that the combination of a really generous welfare state and a high emphasis on equity might create an environment in which those problems are much less than what we found in the mothers to babies study. And so I thought, what if I propose to spend some time looking at food security and racialization in Denmark? And maybe I'll find that there is no food insecurity during pregnancy. And maybe I'll find that there's less racism or less stigma among racialized families in Denmark. And then I can report back and say, Denmark has all we have to do, what are we going to do about it? All we have to do is just make it so that everyone implements a Danish-like welfare state, and raises their children with ligestilling as their top priority value. So I proposed to come to Denmark and look at these things during pregnancy. Back in 2019 and 2020, my grant application was accepted, and I then in 2021 moved here to start running this project. I've been working on it for the last 2.5 years. Before I'd even gotten here, I started going through the Danish literature, and I found they're one and only, Danes don't systematically survey measure food security on a national or communal or municipal level. But there was one national study published in 2018 by Thomas Lund and colleagues that suggested that there was indeed some level of food insecurity here. And around 3 to 5% of households were probably affected. But for various reasons, this team couldn't get into sort of the details of where the small amount of food security that there was here in Denmark, where it was concentrated and who was most affected. Just for context, so that prevalence of 3 to 5% based on 2016 data reported in 2018. For the same time period in Canada, we're talking about sort of a 12% level of prevalence of household food insecurity. So the Danish cases, they're obviously doing much better. They're doing something right. I just want to underscore that right now. But there was indeed food security, so there's something to look at least around the edges. Then, as I prepared for this to work on this project, I started learning about this thing called the Parallel Societies List, or the AKA, also previously officially known and now only informally known as the Ghetto List, which gave me some expectations around where we might actually expect to find food insecurity concentrated. And the most notorious quote unquote parallel society is the neighborhood of Gellerup, just outside of the city of Aarhus, where I live and work. And so I decided to do the formative work for this study on food security in Gellerup, largely. What is the parallel societies list, and why might I have been interested in it? So the Danish national government publishes 3 lists of so-called parallel societies or at-risk Danish neighborhoods annually, based on the previous year's sociodemographic statistics. These neighborhoods are defined by having a population of at least 1,000 people, of which 50% or more are made up of so-called non-Western immigrants. So including not just new immigrants, newcomers, but also like second generation folks, third, yeah. Anyway, that's a whole other discussion about what constitutes a non-Western immigrant. 50% of the population made up of non-Western immigrants, plus any 2 of the following. So 2% or more of the population that's been convicted of 1 or more non-white collar crimes. It's important that they're not all crimes are counted in these statistics, only non-white collar ones. And or 40+% of working age adults are unemployed, and or 60+% of the population is without secondary or tertiary education, and or 55+% of the population with average household incomes are below the regional or municipal average. And it's also like some of these percentages seem kind of weird, and it's because the government changes the percentages slightly each year just to keep particular neighborhoods meeting the criteria. Anyway, that's a little bit of editorializing on my part. What they want to say about that. So that's just some context for the formative work that I'm about to tell you a little bit about. There are some key themes that may, from data collected, I should have had some pictures of the team. I know I do at the end, but so these were data collected by myself as well as 3 excellent master students, Hamdi Igal, Hamda Wabiri, and Khali Ibrahim. And we have done interviews now with, I guess 5 midwives, 7 institute leaders of early childhood education centers, 4 public health nurses, and 17 pregnant women and new moms. And we have plans to hopefully interview some dads and social support people in the near future before we wrap up, totally are finished with the qualitative portion of this study. But anyway, we have both some pregnant people and some care provider perspectives. And what we're finding, or what we found, is that there are definitely people who are reporting at a higher prevalence than we'd expect based on that Lund et al. Study from 2018. We're definitely hearing like a lot of people who are living with some level of food insecurity in this neighborhood. One mom said, "I was just there without enough money after paying for rent, after feeding my older children." This is not a great translation, but to feed myself properly at the end of the month. And then she said this when she was referring to when she was pregnant with her 4th. And another who mentioned that even in the neighborhood, as in Gellerup, it's hard to find the right ingredients for the right price. So as long as the kids ate, I often skipped meals when money and time are tight. This is another participant, another mom. This is not actually to do with food security, but what she said was, we experienced so much racism in Denmark. And now here it is on paper. This is in reference actually to the Parallel Societies Plan, which is the policy not just about keeping those statistics, but about like what to do about these so-called parallel societies neighborhoods. I really hope someone asks me about that, because this is super interesting, but I don't have time to explain right now. Anyway, we experienced so much racism in Denmark, and now here it is on paper that the government views that the people that look like us and sound like us do not even deserve an affordable place to live, where we can also be with our extended families and friends. And so we heard these like multiple stories, both firsthand and secondhand, thirdhand, of families living with food insecurity during pregnancy, and also of families or of people experiencing racism and discrimination, both sort of at a structural level and at an individual level. But then when we talk to the notably, generally sort of ethnically Danish, white health providers and institution leaders, we heard quite a different set of stories. So one institute leader, childcare institute leader, said, poverty plays into diet, but in reality, cabbage isn't super expensive. It's about knowledge and convenience. Making the decision to like buy less healthy food is about knowledge and convenience, is what they meant. And another one said, I actually think that what I encounter most is the social understanding of what is healthy in the immigrant families. We see children bring 2 pieces of toast with Nutella as a packed lunch for the whole day. So some of it may be due to economics, but it's also about what the children like. And what my students and I really, if those were just a couple of one-off comments, we maybe wouldn't have made much of it. But my students and I have been through the transcripts now of these provider interviews pretty carefully. We've coded them, and this is something that comes up again and again, this sort of dismissiveness of the idea that food insecurity is like a major determinant of health, it's quite a striking contrast to what we actually heard from the moms so I think to sum up, actually I'm gonna wait, I gotta show you the quantitative data. Okay, so we've been running these focus groups and interviews, is collecting qualitative data for over 1.5 years to almost 2 years or so. But then we've also, since the beginning of this year, had a survey open. And I'm just going to talk about the data from pregnant people. We have lots of other responses from other sorts of people, from moms, from dads, from health providers and various other perspectives, but just this little bit of pregnant people data. We have 62 responses so far. And what we found is that there seems to be a pretty high prevalence of marginal household food insecurity. This is on using a sort of a validated food security scale, unlike with the M2B data. And yeah, about 26% of this admittedly small sample reported at least marginal food insecurity. And it actually seems to be slightly higher among people who I expected maybe there would be sort of like a racialized pattern that would start cropping up almost immediately, but there isn't. If anything, the ethnic Danes are slightly more likely to report worrying about running out of food before the end of the month than the racialized or newcomer respondents. When we also looked at this change in overall health, like we did with the Mothers to Babies study, and I haven't really figured out how to show this well, but basically as in the Canadian sample, most people reported slightly worse overall health during pregnancy than pre-pregnancy, and there isn't a clearly racialized, but unlike in the Canadian data, where there was no question a racialization pattern with respect to that, that doesn't seem to be the case in these data, but there's lots of, again, super small samples, super biased, all kinds of weird things about it. So I don't want to make much of that. The other really, really interesting, super preliminary result is this one. We had like lots of attrition from, it seems, among the people that actually live in these parallel societies neighborhoods in terms of completing the survey. Even though it's actually a very short survey, but they found it hard, I think. So we actually only had 6 respondents who live in these parallel societies out of 62. But all of them were marginally or moderately food insecure. So there's definitely a geographic pattern there that's worthy of attention. Well, wouldn't say definitely, might be a geographic pattern that's worthy of attention. So just to recap, just to sum up what we know about spoons so far, about the Danish case so far, is that we heard about that stress, that we heard about financial stress to some extent. And we definitely heard about the neighborhoods being stigmatized. We definitely heard from pregnant people and new moms about increased exposures to or lower food quality. But then I didn't talk in this particular talk about the housing side of things, but there's also like lots of interesting things around housing and housing policy. And I would like to underline this point about respondents noting and telling stories about experiencing racism, both structural and individual. I put together the slide for another talk but I actually only want to say one thing about it right now, which is that we know that all of those 4 themes that I just mentioned, that they have like clear biological consequences, which I think there are good reasons to think that because of these themes that are cropping up in the spoons data, they are affecting the in utero development of embryos, fetuses that probably have implications for subsequent growth, health, and development. Okay, so what do we know about the Danish case versus the Canadian case? Anything so far? So I raised a couple of questions. Is food insecurity in pregnancy really a problem in high-income countries with generous welfare states? Yes. Data that I showed you today are that in these 2 very rich countries that both pride themselves on universal health care and provision of basic social supports, there are pregnant people who are experiencing food insecurity, which we know from systematic reviews, etc., is linked with negative health consequences, as well as from the data that I just showed you. Does having a more generous welfare state help? Yes, it's not a silver bullet. There are Danes who are food insecure, and particularly in these so-called parallel societies neighborhoods, both the qualitative and the quantitative data are pointing in that direction. But the numbers I showed you for Denmark are misleading in a lot of ways, and as I mentioned, there's a lot of shortcomings with those quantitative data, and it's very, 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 very preliminary. So while household food insecurity is affecting some pregnant people here, it's not as deep and traumatizing as what we heard about in Hamilton, where like there was no avoiding those conversations. Every interview we ran in Hamilton, people were like, you gotta do something about food insecurity. What is the role of health professionals in food security screening and support? I don't really know, but in Hamilton, midwives, public health nurses, dietitians, other health and social care professionals have to be aware of HFI, of household food insecurity. They have to you have to normalize it, have to figure out workarounds, etc., because the structures are such that at least 1 in 6 households really don't have enough money for healthy food. So like, if you're going to support pregnancy health at all, you have to have at least engage in the conversation around food security. In Denmark, health and social care providers should be more aware, I think, more aware of the reality of household food security and insecurity, and should work towards destigmatizing it. But the need is less, even in these hard economic times, and it's different. But there are some real. But one of the things that is coming out of these Danish interviews is just how much stigma there is against how many sort of preconceptions there are among ethnically Danish health providers who are working with visible of newcomers to Denmark who are likely to be racialized. What about racialization and food insecurity? How do these factors intersect, and what might be important about them in what contexts? Well, in both survey data sets, there isn't necessarily a clear connection between racialization and household food insecurity. I didn't actually really, I didn't show that clearly in the Canadian data, but there wasn't an overlap between our measure of food security and racialization. There wasn't really a difference. But the qualitative data probably tell a different story, again, in both contexts, and suggest that there needs to be more attention to whether or how these factors might work together to affect pregnancy health and experiences, in particular for newcomers. And the conversation in Canada, like after we collected the M2B data, my impression is that it's really, really moving in that direction, that there's not only a public debate around food security and economic supports, but there's also like a real push particularly since summer 2020 to making sure that like anti-racist efforts are in place and part of like healthcare provision and considered in when we're thinking about social determinants of health. That has not really been the case here in Denmark. That's actually basically about all I have, other than that. I think that there's, oh, my cat is now meowing. I think that that these are like, that both racism, racialization, and food security are top line priorities for thinking about health equity when we're both as for practicing clinicians, but then even more so when designing policy. And there's clearly a need to make sure that there are the right income supports in place in Canada so that people aren't falling through the cracks and experiencing pregnancy without enough money to buy healthy, socially appropriate food. And in Denmark, there really needs to be some policy changes around the concentration of a negative attention on non-Western immigrants. And then also some extra, probably structural economic support for some of the people who live in these neighborhoods. I just want to end by thanking the Mothers to Babies team, including co-PIs, Mary Barker, Stephanie Atkinson, Stephanie McDonald, Beth Mary Davis, and Megan McConnell. And of, did I not put Deb's name on here? Oh my goodness. And of course, Deborah Sloboda, who I mentioned earlier, who's the PI and mastermind of the Mothers to Babies project. And to thank all of the amazing research assistants and public health partners, and especially the participants. And I want to thank my amazing Little Spoons team, McMaster students Julie Lerabritiosa and Kate Kaplan, who worked on the evidence synthesis, my master student Hamdi Wabiri, and my research honor student Khali Ibrahim, and my Hamdi Igal, who is my practicant, blanking on what it's called, intern, master's intern, here at Aarhus University, and Diana Hoytoft, who is a PhD student, an incoming PhD student who helped out with project as well. So thank you, Amazing Spoons team, and community partners and participants, as well as all of the M2B people.
So much. So we're going to stop our recording there just to allow enough time for questions. I don't know, Rash, if you want to put that last, I don't know if we can put the last slide up, but it's nice to obviously acknowledge the team that's been a part of everything. But yeah, we would love to have some time to ask you questions. So thanks again, Luseadra, for joining us and for raising, I think, some really important topics. I'm looking at who's on the call, and I wish there were more Hamilton midwives here. We'll have to have you back to kind of talk to our group specifically, because I think there's so much for us to take away. But yeah, I will pause my yibber yabber and see if anybody else has questions or things that they want to chime in with, or if you have any kind of comments as well after the presentation.
I just want to say thanks so much for inviting me, and I would love to share with Hamilton midwives, because Hamilton midwives took so much time of their time to talk with us when we were running the Mothers to Babies study, and I learned so much from them. So it would be nice to share something back in return.
Yeah, I'll have to do that. Okay, if anybody has questions, feel free to just put your hand up, or you can pop your video on and unmute.
If no one has questions, that's okay.
We'll have a little bit of time. Hey, Rebecca, go ahead with your question.
Sorry, I'm kind of multitasking. So I appreciate your presentation. In Thunder Bay, we're also finding with the populations we were working with, there's a really high degree of food insecurity and like a low degree of knowledge on how it affects, especially like pregnant people and families postpartum. And I'm wondering if throughout your research or in Denmark or anywhere, if you've seen any initiatives that have been really successful in addressing it and what kind of the role of the healthcare provider might be in these situations. I find we're doing a lot of connecting people and outreach work for them. And I'm wondering if that time is better spent with somebody who knows the system quite well and can connect them. At our CH, so we work at a community health center, and there are dedicated professionals that are community health workers that are pretty helpful in these situations. But we find we're tapping on outreach frequently to just pick up food boxes and deliver them to people. And it's a Band-Aid solution, and we really struggle with it. So I don't know if you have any good examples or in the literature of other things that might be more helpful, more sustainable.
That's a great question. And unfortunately, I don't think that there are any. I mean, there have been a lot of initiatives but it's in different places, and particularly in various states in the US. I know that there are municipalities in California that have tried to tackle food insecurity among with a particular focus on families with young children, and also with the idea that it also sort of encapsulates the interpartum period and pregnancy to some extent. And those are some of the only ones to which I'm aware of, that there have been some sorts of relatively systematic evaluations of some of the interventions that have been developed, but again, they're typically kind of they're maybe better than sort of these really Band-Aid solutions, stopgaps of just giving out food, but we're still not talking about anything that's necessarily truly sustainable. We're talking about little bits of income supports that are then potentially affected by when either the research project funding runs out, or when the legislature changes and decides to stop funding the program. So I actually haven't seen anything in any literature from anywhere in the world of anything that's like sort of an intervention or a solution that looks sort of 10, 15, 20 years down the road and looks at the outcomes of the feasibility of the intervention, and as well as the sort of like biological, social outcomes of the intervention. So yeah, I don't unfortunately, I don't have a good answer for you. And I think that everyone in different around the world is sort of when faced with various crises that make food insecurity worse, just sort of pull out small short-term stopgap measures and try to make sure that people don't starve, which is, it's not good enough. I didn't really answer your question.
That's okay. That's sort of the answer we're coming up with too when we do research. So unfortunately, I just was hopeful you might have more.
Unfortunately not. But thank you for the question. I appreciate it.
Yeah, thanks, Rebecca. And we've got a poll up to provide some feedback on the rounds today. Any other questions from the audience? I think, listening to you talk, I think about the gaps we have in the questions we ask and the gaps we have in the data that we collect. And I think about, in Ontario, we collect our born data, which is supposed to capture everything about, pregnancy, birth, and the postpartum. And I just think of how much we're missing on there. We don't, there's nothing that would capture stuff about nutrition or food security or housing. We don't even have proper ethnicity data reflected in that. There's just so many gaps for us to be able to understand and really unpack some of these bigger issues and the intersection that you've described, right? How housing, financial stress, food security, racism, how they all intersect, and then, to be able to look at them over outcomes and kind of what that trajectory is using that DOHaD hypothesis. Like it's fascinating stuff, but I think of, how far we still have to go to even know what to ask and how to gather data to unpack it. It's a challenge.
Yeah, I agree. And but it seems like that Canada, sort of from a national perspective, is definitely moving in the right direction, and the conversation has really changed in the last couple of years, at least around monitoring of of the racialization experience and how that affects health. I'm cautiously optimistic that in 10 years' time there will be like much better instruments and tools in place for thinking about that.
Yeah, I'm glad you're optimistic. I hope that optimism continues and that we can channel it into ongoing action and good research to continue to ask good questions and find out how we can help people. So yeah, I think this has been really fascinating, and I'm sure you have lots more that you could share with us in your data too. So we'll have to think about ways to have you back to keep unpacking it further. Any final questions from the audience? I know we're probably just 1 minute away from our wrap up time. Lots of
thanks for having me, everybody.
Yeah, lots of thanks in the chat. I think it's been a really important rounds for us to think about, and you know, again, particularly with our local Hamilton group, it'd be great to be able to share this in some other capacities. So why don't we wrap up there, and thank you again for coming and speaking to us today and for being the last speaker in our round series. We are in the process of planning our rounds for the 2023-2024 season. So if people have thoughts or talks that you've enjoyed over this year that you'd like to highlight or that you'd like to hear more about, please send us that feedback. And yeah, we're going to be, I think, trying to streamline the process too. So that should make it easier for people to know when to come to rounds and how to get here and all of those things. So hopefully we'll see more folks in the months ahead. And yeah, as I said, we're going to pause for the summer. So we'll be taking a break from our regular rounds. But all of our rounds from this year are available on our website with the videos. So please share them with folks who you think might have wanted to be here and weren't able to join us. And keep heading back there for new content. So thanks again, everybody, and for your feedback as well. So we kind of keep tweaking and revising things based on those polls that you fill out when you're here. So we appreciate the input. And yeah, go enjoy the sunshine and the warmth out there. And thanks again, everyone. And thanks, Luseadra.